Thank you. Hey, everybody. All right. It's great to be with you here today, and just first of all, thank you for what you do. Thank you for all of the kindred spirits here who stand up for others, who fight for others. We're not looking for a fight, right? But sometimes you have to speak up and stand up to make sure people get a fair shake. And I found that I'm wired like that. I found that it's really not just a job for me. It's kind of who I am, and I'm guessing maybe you can relate to that. As one example, my wife and I are foster parents, and so it impacts our personal life as well, that we've taken home around 6 babies from the hospital, and we've had around 30 or so kids come through our home. It's really tough, but it's just, when you're just wired that way, I guess that's the path you take. So I'm from Wisconsin. There's some Wisconsinites here. So Wisconsin is a very cool, very unique state. We are, if you didn't know this, we are the number 1 in cheese. That's why we are the cheeseheads. We're the number 2 in dairy. We are, if you look up the cities that drink the most, we have like 12 of the 15 cities. So we like to have fun. If you're ever in Wisconsin, look me up. I'll buy you a Spotted Cow. Have you heard of that? A New Glarus Spotted Cow beer. But one thing that's not so good is that we're actually, according to the last RAND study, one of the 5 worst states for healthcare cost. Yeah. And so with that huge problem we have, in fact, it's not uncommon for us to average 300 to 400% of Medicare, and like the discounted price, if you will. And so that's a problem, but it's also opportunity. The bigger the problem, the bigger the opportunity, in that when we go to fix it, we can really save a lot of money. We can get better care at a less cost. So we'll talk about that. So I find myself on a very unexpected journey. I had I guess somewhat of a normal career, an HR career. I wasn't maybe the most typical HR person. I was always trying to change something or fix something, and sometimes the corporate world doesn't like that. But I was always trying to help people. And so I was 25 years in mostly manufacturing. And the first 2/3 of my career, I would say I was working my way up, so I had less influence and less decision-making authority, but I would do the enrollment meetings, right? So these lights I can't really see you at all, really, but just show of hands, who was on an employer plan? So, yeah, looks like a fair number, right? So I think Nilsa had pointed this out, when we're all actually patients, too. We work in the healthcare field, but we're all patients, too. And so we're going to talk about kind of employer health plans today and how we have found a solution for that. But the first 2/3, I was passionate about staffing and great place to work. Worked for Badger Mining, which was the number 1 great place to work in the nation. And that was my passion, to teach leaders to lead well and create that culture. I took a job in 2016 with a company called Merrill Steel in central Wisconsin in Schofield. And almost immediately when I showed up, the owners came to me and said, we've been having the last 5 years these out-of-control healthcare cost increases. We've been absorbing it ourselves. We haven't been passing it on, but we can't keep doing that. We're going broke. Is there anything you can do? And that was my spark to start learning about maybe the depths of healthcare, all the things that the game, not necessarily that big insurance handed us, but how healthcare really works. And so I found that there was very little to read on that. I searched Amazon and so forth, and ended up writing a book later, which actually there's free copies available after this. They're out there. So we'll talk about that. But we ended up, over the next 5 years, we transformed our health plan. Basically, all new partners, we found trustworthy partners, and all new steps. We increased the care greatly, but we had saved over that time about $5.5 million total. Employees saved 20% of that, so you can do the math. Over $1 million employees and their families saved. And we had same or next day on-site care and specialty care, and everything was kind of no cost after that. And so we'll talk about that. And that led then to co-founding with a guy I met from Madison 2.5 years ago, a company called Self-Fund Health. So we took that proven health plan, and now we're taking it to companies all across the state. And we have some from the Self-Fund Health team here today. So up to 11 employees in 2.5 years, and we're in all 5 regions, so we're growing fast because there's such a need for help there. and then wrote the book. The book is, in the first year, sold almost 5,000 copies, and it's led to me speaking everywhere on this topic of free market economics, free market healthcare in 25 cities in the last 12 months. So glad to be here. So let's talk about some of those things. Let's talk about how we did it and maybe how it can help many others. So employer health plans, by the way, if you're not familiar, about half of the healthcare in America is what we call on the commercial side, the non-government side. And so we call those commercial health plans. And then 2/3 of those are self-funded plans. So self-funded plans just mean that it's not this pay a premium where the insurance company takes all the risk, but actually the employer is taking some of the risk with what we call stop loss, which is just more of the extreme coverage at the top. So it's a big deal, and there's a fair chance that many in the room that your employers are on self-funded health plans. So really it's fair to say, I think that as how these health plans go and whether they become sustainable or affordable again, is how American healthcare is going to go, much the same. So I'd mentioned this, I'm not going to get into extreme detail, but it's a really neat story. It's become well known. This was something we started and we had no idea how it would go. This was pioneering at this point. It's now a proven way that many are taking. But we had those unsustainable trends and we had to change it. So I'm pleased to say that Merrill Steel today is on their 8th year of frozen premium. So I'm not sure what you're hearing when you go into enrollment meetings, but kind of cool. They get to go in and say it didn't go up. And everything after the premium, if you take the path of preferred providers, is no cost. So that's pretty cool. They also have low premiums. They protected low premiums. It's around $50 a month for single and around $160 a month for family. So really low premiums as well, and really great care after that. We were creative. We bought an ambulance that we wrapped, and it was like a rolling billboard and the difficult staffing. We had two choices. It was kind of funny. We had one ambulance, like who shops for ambulances, right? So me and the president drove down. This is kind of crazy. The one from Chicago said no. One from Iowa we bought said no smoking. The one from Chicago said no guns, and so we chose the Iowa one. And the Iowa, it was like new, but it was like 20 years old. So, just a really neat story. And so that's one of the examples of several in Wisconsin of companies that have actually done that. So. If you're trying to understand what we did and how we did it, we essentially just kind of tapped into free market economics. I'm not an economics major. I've always studied, transformational leadership and human behavior and psychology and things like that, the HR stuff. But I had enough, I guess, on just free market economics. And what we're really just after, we're not against anyone. We're not trying to make enemies. We're not trying to fight. But we want choice and we want options. Right? When we go and shop for a TV, we have many options and we get to assess value. And when we go to a restaurant, we have many options and we get to assess value. And if we have a bad experience, we don't go back. And that kind of requires that restaurant to get better, to get their prices down or their food better or their service better, or they don't stay around. Well, the healthcare industrial complex has kind of monopolized things where it's like you can have a bad experience, you can get an exorbitant bill, you don't know the price before you buy it, and then you have to go back, and that's not a healthy situation. That's a kind of a handcuffed type situation for the buyer. So really cool stuff is happening in Wisconsin. We're essentially creating a new system. We're juxtaposing a new system alongside the old traditional system. Sounds kind of crazy, right? But there was an article in the Madison Journal that said in 2020 we had 15 DPCs. So I don't know if you guys know this language, direct primary care. So essentially independent primary care, doctors that have left the hospital systems. And today we have 126, 4 years later. That's how fast. So guess what? Doctors and nurses are just as frustrated with their loss of medical autonomy. And they just want to care for patients like they went to school and what was their dream. And so they're getting a chance to do that in this free market. And then we're seeing the same in the specialty care. We call it DSC. Direct specialty care. It's really just connecting the buyer and sellers of healthcare, which we'll talk about. But if you look at the bullets, so there's imaging, there's infusion, surgery centers. What's interesting, if you go back just 3 years, there's only 3 bullets. That's how fast this is growing in Wisconsin. So if you're a physician or a nurse and you're looking to work for an independent provider and maybe get to practice how you'd like, 30 or 60-minute visits, relationship-oriented, reasonable panel sizes, come to Wisconsin. I know many of these are hiring. I'm not here to recruit, but maybe a little bit. But we're moving in Wisconsin, and the joke, of course, in Dairyland, we're moving. So you get my humor as well. You get my dad jokes. But yeah, lots of cool things. So we actually now, when you think, well, okay, we can do about 70%. So there's still a need for traditional systems. And again, we're not against them. We just want them to share their price and kind of break away from maybe the big insurance control a little bit. Long term, we'd like to see the hospital systems be right with us. We'd like to see the broker advisors right with us, and just anyone who's willing to share prices and give fair prices. But we're seeing micro hospitals. We saw one pop up in Green Bay, and also then there's going to be one in Milwaukee. So we're even getting into independent hospitals, again, where the doctors and nurses get the care maybe that, according to their dream, is when they were investing all that in school. So that is a little bit about the Wisconsin movement. I thought I'd have a kind of a fun quiz. So if you happen to have a piece of paper, if you don't, that's okay. But if you'd write these down, so there's 5 things here, and you can just make little abbreviations. But I'd like you to guess what you think, or maybe what they are in your state. Wisconsin might be different, probably higher. But just what you think these cost. So for instance, write down what you think a comprehensive metabolic lab panel costs. And this is just for fun, of course. And then I guess wherever you think the best price that you can shop, if you're aware, yeah. So hospital or wherever if you were to buy one, what would it cost? And then MRI. And we have the answers, at least from a Wisconsin standpoint, which I think are somewhat typical in a little bit. But MRI, and then a joint replacement, so you could say knee or hip. And then colonoscopy, these are just some typical procedures, right? And then lastly, gallbladder removal. So in a few slides, we'll look at what those cost. So one of the things that I learned as I was going through this, as I kind of had to do this self-education, is just the flow of money in healthcare. And one of the most interesting things is the CAA, the Consolidated Appropriations Act of 21. It's coming in phases, about kind of one big thing a year. And I don't have time to dig into the details, but there were several things that did for the health, if you will, of shoppers of healthcare, for those that would like to shop for healthcare and not be tied. And so one was price transparency. Another was the removal of gag clauses. So if employers were supposed to have all of the gag clauses out of their contracts legally by the end December of last year. I don't think most did. But gag clauses say that we can't share your own data with you, which is crazy, right? Compensation disclosures. How much are your partners making? So you see the arrows on this slide. The arrows on top reflect money that the buyer, the true buyer of healthcare, by the way, is the employer and the employees of commercial healthcare. They're the only payer. Sometimes I hear, like I was talking with someone earlier, we call the insurance company a payer. I call them a reimburser. They're just passing along the employer's money, aren't they, and employees' money? So they're really a reimburser. And so when we connect buyers directly with seller directly, which is the one providing the health care, we can do amazing things. And when we start to understand the money, so the arrows underneath reflect money that the employer doesn't see or is not aware of, right? All the commissions and overrides. And I saw some research recently that said that there's 7 lobbyists for every congressperson in Washington. 7 for 1. And so the government's role really in this free market economy is supposed to regulate and supposed to trust bust, right? It's supposed to make sure there's no monopolies. But when you have 7 lobbyists, what are the Congress people hearing? They're hearing a slanted story about, the big insurance, if you will. So that's kind of the flow of money, but essentially what we're doing is we just want, we want to buy healthcare. So buying healthcare is very different than buying insurance. Now, that doesn't mean that health insurance isn't needed in some cases, but we want to, just like I learned at Toyota, I worked at Toyota Motor Manufacturing way back in Kentucky, and I learned that Lean is essentially taking out the steps in a process that don't add value. And we keep all the ones that do, and you end up with a very efficient, affordable system. So flow of money. And compensation alignment's key. One quick point on this. Compensation alignment, we learned that the three on the seller side, if you will, there's only one true seller, but all of those three entities currently in the way this game is set up, the hospitals, which you would expect, any seller wants the prices to go up, that's normal. But then the big insurance is in the middle, and then the brokers who are kind of representatives of big insurance, they're paid on a percentage of claims, so they want the claims to go up because of ironically, the Affordable Care Act really has caused prices to skyrocket because it said that insurance companies get to keep 15% of the medical loss of the premiums based on the medical loss ratios, but 15% of premiums, so they want 15% of a smaller number or 15% of a bigger number. They want prices to go up. So everybody but the buyer wants prices to go up, and that's exactly what's happening. So we've got to change that. If you're working with a broker or anyone's working with a broker, you got to make sure that their pay is aligned, that when your plan falls apart, they can't make more, right? There should be alignment there and making sure that when the employer does well, then everyone does well in the opposite. So I had a couple aha moments at Merrill Steel. This was way back around 2017. We had the custodial team, and no one really would help them. So of course I raised my hand. I said, okay, they can report to me and I will support them. Well, we had this vacuum. It was about 10 years old. We fixed it 3 times. It was like this industrial thing, and it broke, and we needed a new one. So I went to the purchasing department, and they gave me their process. Anybody ever done that where you got to fill out 3 quotes and all that? It's actually a good process, right? But I found myself that afternoon spending 2 to 3 hours, and it just felt like we made the decision in like 5 minutes, like just by the same vacuum. Like this wasn't a hard decision, it was the best deal. But I was spending all this time, and I thought, wow, just that morning I had signed our stop-loss agreement for our health plan for $700,000, and all I needed was a nod from the CFO. I didn't go through any purchasing process. That was the point that I realized, this is every employer, I think, that healthcare and what we call benefits inside is not perceived as a purchase. Yet for Merrill Steel, it was the 3rd largest expense of the whole company, right behind steel and wages. And so we have to put it on the radar and see it as a business expense. We have to see it as purchasing health care. And when we can do that, we can start to find value. Probably the most relevant example, I use this in the book, that I can give is that the auto industry. So when I was at Toyota, I met this general manager. His name was Ken. He was a big guy. He was a linebacker on his football team. He was toward the end of his career, but in the 70s, he was a first-line supervisor at a GM plant. So if you remember those days, things were very different back then when there was the actual big 3. That's changed now. They're no longer the old American big 3, but GM, Ford, and Chrysler. And he said that the UAW would play really rough with him. He said they would smoke pot on the line. He said half the cars rolling off the line started. These were brand new cars. And he said that if he upset him too much, he had this metal desk on the floor, they would turn it upside down in the plant. So they gave him a hard time. He wasn't afraid, but you're right, it was just this combative environment. So these 3 were alongside each other, but they pretty well had their market share there, right? They were competing, but kind of, sort of. They knew they would sell, even if they weren't great, and they could just kind of muster along. Well, then in the late 80s, here comes Toyota here in Georgetown in their flagship plant in Kentucky, Honda, Marysville, Ohio, Nissan, Smyrna, Tennessee, etc., many. And they started to raise the bar, right? I was talking with one of our trainers at Toyota one day in Kentucky, and he said, yeah, my Camry's about to hit 300,000. All I've ever done is brakes and battery and tires, but I guess I should replace it. Still runs great. And so they raised the bar. And so the American automakers that weren't maybe so great, right, before had a choice. They would either have to get better or they wouldn't be around. That's what a free market looks like. And guess what they did? They got better. So they even asked to have a tour of the Toyota plant, and the Toyota said yes. That was crazy. They said it's hard to copy even if you can see it. But they were the best at problem solving and many other things at lean manufacturing. They wrote the book on that. But that was what happened. If we look at where our auto industry is today, if we go car shopping, we have a wide variety of choices, and most every car company is pretty high quality. So that helped the consumer. It also helped all the sellers in that case, and that's what we need in healthcare. This was a picture that I used. I called it Current at Merrill Steel way back. We still use it today, but this was kind of this one-lane road, right? Kind of like this monopoly, like there's nowhere else to shop. You're in network. So even if you have a bad experience or it costs too much or you go bankrupt, you still have to go back. Did you know that 2/3 of the bankruptcies in America are related to healthcare, and 3 out of 4 of those families had a health insurance plan? How does that happen, right? It happens that the health insurance isn't really, you have this card, but it's not really covering. You're still going bankrupt if you have to use it, or you're avoiding care altogether until it gets so bad. So we said, my goodness, so here I was in these shoes, and the owners are looking at me, and they said, what can we do? And it's in the introduction of the book, but I also was actually run over by a 4,000-pound tractor. So if you like a little drama, it's actually a true story, but that's in the introduction of the book. But that really motivated me. I had a bad healthcare experience with ER and with the billing, and I shouldn't be standing here. I probably shouldn't have lived through that, but I did. And it motivated me. It's been fuel for my fire. It's motivated me to go forward. And so here was the picture I used as future. So this is what this company that we created called Self-Fund Health. We are a health plan. This is how we do it. And so what we want is shopping for value, and we want choices. Members on the Merrill Steel plan, there were about 1,000 of them. They had a choice. Members today that we work with have a choice. They can go to the traditional side, and they would have their old, because it's more money, they would have their old deductible and co-insurance and max. Or if they go to typically an independent, it doesn't have to be, but someone that shares the price and has a good price and great quality, it would be no cost to them on what we call the paved road on the right side. And a lot of it may depend on state, because when I was with Merrill Steel, we negotiated a direct contract with Cox Health in Missouri at like 132% of Medicare. So that was an example where the hospital would have been on the right side. I think in Wisconsin, it's not that way. This is how the picture would still look in Wisconsin. I would hope in 2 to 3 years that we can move over the hospitals, and that they would come with this movement that's moving pretty fast. But we're really just after value, and that little clinic represents the DPC, so we have 126 now in Wisconsin, and you can go to that DPC, same or next day care, at 0 cost. You can go as much as you want, 30 or 60-minute appointments. You can text the doctor or nurse outside of the office and get help, and it's accessible and affordable. So here was our little quiz. So if you have the number in your mind, here are at least the numbers that we see. Only let me do one click here. But so a lot of times we're paying hundreds of dollars for a comprehensive metabolic lab. The actual cost through, and often you think even the hospitals use these companies, Quest or LabCorp, $3.58. That's how much it actually costs on the free market. Kind of crazy, isn't it, the markup? And some of these are, like in Wisconsin, the 7 biggest hospitals are nonprofit, but for some reason, maybe it's Buca influence, but they're marking up these significantly. In Wisconsin, we're used to seeing $4,000 to $10,000 for an MRI, but we can get it on the street now. This wasn't the case years ago, even as little as 3 years ago, but we can have a brand new wide bore GE machine that still looks and smells new. It's like just out of the factory for $600 in some cases less, even with contrast in that range, maybe $800. Joint replacement, I've heard as high even as $160, depending, they're always different. But that would be the typical range for a joint replacement, where we have free market. We have one in Milwaukee, we have a new one in Manitowoc, we have Green Bay, we have different places. The west side of the state, we can get it for around $20,000. And that's a 90-day warranty. So the quality is good from a hand-picked surgeon. Colonoscopy is still a gap. We now have a couple in the state that are affordable, $2K to $10K, and there's such a range there. If they find polyps, this is after the fact. It's like whatever, $1,500, $2,500 per polyp. So that price could get pretty large pretty fast. Or we can just find one for $1,200 to $2,000, $2,500 maybe, depending on the place. And then lastly, gallbladder removal, right? When we can shop effectively, we can get that for around $6,500 instead of the standard $1,200 to $2,400. On the left side, they really don't tell you the price, by the way. You have to look at the claims and so forth. One of the things that we have that's really cool about our health plan is that we have real-time access to claims data and pharmacy data. That's kind of unheard of. If you're from the old school, we used to request the spreadsheet 2 to 3 months. By that time, everything's over, everything's old. We actually see it real time, so we actively manage this health plan for employers. We have a nurse team. Some of them are here today. They reach out to the members and they say, hey, I've got a free MRI. Are you interested? And or let me help you transfer your medical records or make an appointment and all sorts of probably other crazy things, but they're basically hand holders and saying, we're here to help you figure out this complex healthcare game. Yep. So if you've ever been through a change, people love to change, right? They're just anxious to change. It's really easy. Yeah, all the time. So one of the things I've done in my career is lead change, and it's like, even as I've learned a lot about it and know a lot about it, it's like still really hard, right? There are some things you learn along the way that make it easier, but if you've ever heard of what's called Rogers adoption curve, this is at least a graphic with some research a while ago, quite a few years ago, but of what it looks like to lead others through change. Anybody ever played the game Red Rover? I'm really showing my age here. I'm 51 now, so I've got, I tell my kids I was born in the 1900s, but I'm still young enough to travel around and do these things. But Red Rover was a game where you had two sides, and then the kids would hold hands, and then it's really simple. And then you would call Red Rover, Matt, come over, and Matt goes and he tries to break through. He tries to pick the weak link and break through, right? And if I break it, then I get to take one person and go back to my team, and if I don't, I have to join that team. Really, that's the game right there. But leading change is kind of like Red Rover in that we're trying to get the most people on our side. So we're trying to win them over. We're trying to say, this is a good direction to go. You should come with us, right? Kind of mentally, I believe in this. And so you start out, there's innovators, there's some people that are like right away, right? Early adopters and so forth. And there's some that kind of maybe never really want to come, or they wait till the very end. And that's normal change leadership. It says 100% if you look at that cumulative curve. I'm not sure it's ever really 100, but it gives you at least an idea. But that is not an easy thing. If an employer is talking about changing a health plan and transforming it, this cannot be ignored. In fact, this is really the predictor. This is the biggest variable, because now we know how to do free market healthcare. We know how to shop, but you have to lead the people through it. One of the biggest nuggets there, I'll give you a quick nugget, is that before someone, a lot of times you talk in management meetings, right? And then we say, these are the problems and this is the solution. And then you've talked so many hours about it, you just say, this is the solution. So then you go and you get in front of employees of the bulk workforce that's never heard of this, and you say, here's where we're going. Well, the problem with that is before you go to a new place, you have to be willing to leave the old place. And so you have to get them to detach. So you have to go back and talk about why we can't stay here. There is where we need to go, but here's why we can't stay here. And when they let go, they'll be more willing. But that's often missed, I found, in change in corporations. So kind of as we move toward the end here, kind of a humorous comic. But really, I think what seems obvious maybe isn't all the time. So we have these, I call it, in the book, I call it a lot about a win-win relationship, right? So win-lose relationships never sustain. And in healthcare today, we have a win for the seller, at least for big insurance, if you will, and then we have a lose for the buyers. We have an unsustainable trend in most of the states of our country for the buyer, that they're driving toward a cliff and they're not braking and they're not swerving. It's simply not sustainable. And I call it golden rule compliance. So whenever we have relationships and partnerships, we all have to treat others like we would want to be treated. We have to find a win-win. It has to be a win for the doctors and nurses. It has to be a win for the employer and the employees. And it has to be a win for the hospital. It has to be a win for everyone. But if there's losses or losers in that relationship, they're not going to be able to sustain. So we seem to be kind of running over our fellow Americans in many cases, right? And I think this is really cool, the group here, because we're fighting for those that are on the losing side. We're trying to help them, often in a broken system. What we did, we said, this system's so broken, in fact, those that are profiting from this, it's not a problem for them. Sometimes we're waiting for as we call the healthcare industrial complex, to fix these problems. It's not a problem for them. They're not going to fix it. So the only way to fix it is to open up this free market, because if we don't feed the beast as the joke of the book, right? The beast is not a specific person or entity. It's just those that break the golden rule, those that want to win and they want everyone else to lose. So as we starve them, they'll have to play fair. They'll have to share prices. They'll have to have fair prices. They have to have good quality. They'll have to have good accessibility. And so that's all we're after, is just win-win, sustainable situations. So a lot of that relies on trust. I call that trustworthy partners in the book. And I realized this at Merrill Steel. I realized that for 2 years, I'm like, here's why we can't stay here. Here's where we're going. And I'm like getting exhausted. Nobody's coming with me. These are the partners that I'm paying to help me manage this self-funded health plan. And I'm scratching my head, and I can't figure out why they're not coming with me. And so I did some compensation requests, both the arrows on the top and underneath. I want to know all you're making off my plan. I want to know who's paying you and how much. And that was even before the law came out. And then when I got the results, I was very surprised. I realized why they weren't coming with me, because their were making more on the other side than what I was paying them. They weren't really working for me. We work for who pays us, right? So we had to align the compensation, but I found that I didn't maybe have the most trustworthy partners. Ended up changing all of my partners, right? Here's an example, right, that we talk about gag clauses in contracts. So if I'm going to give you a contract, like we're going to be a team, we're going to work together, and here's a contract, and I'm like sneaking all this stuff in the contract, why would you want to work with me? Like, who has time to check contracts or watch a partner that's supposed to be helping you when they're playing games? I said, I don't even want to work with you anymore. I found partners that I could just trust, that when I wasn't looking, they were doing the right thing. They didn't sneak stuff in contracts. It's amazing how easy life gets when you can actually trust the people around you. So I actually spoke in Wichita. I mentioned the 25 cities. I spoke in Wichita, I believe it was February. I wasn't here, but this is actually from Wichita. I found this. I've been using this. So if I click this, will the video play? We'll give it a shot. So this is just a really short but a funny video on trust.
And it'll be an exercise in building trust between one another. So Harrison, if you don't mind going first, step up here on this chair and close your eyes. All right, and then everybody fill in, and we're going to ask you to fall, and then they will catch you. So you have to trust us. So I'm going to count to 3. Just relax and fall. Okay? 1, 2, 3. No, wait, no!
All right. He will probably never do that again. He was probably scarred for life. So it's really important. The trust fall is actually meant to build trust. But it's really important that we trust who we work with, right? Because we don't have time to review contracts or find out who's sneaking what. And that was a big way of that we win today and how I've won in the past. And so, showing about 6 minutes left, so I think we do have some time for questions. Here's some information if you'd like to reach out to me. There are signed free books. If we need to sign more, we can out there. And this is really just how I did it. It's kind of my story. And like you, I find myself to be an advocate. I'm not really sure why. One of the things I didn't mention that's not in the presentation is that I was bullied almost all through childhood. Looking at me today, I'm 6'5" and 250, and you may find that humorous. I was small and scrawny and really quiet. So I don't know if that was why. But I have this desire to stand up for others. If I'm just like anywhere now, if I'm in a restaurant and I see someone being abused, like I will be willing to step in and help. It's just it's a drive that I have. So I think Ann or someone had asked that question earlier. Why are you an advocate? That's why I'm an advocate. I believe that standing up for people is the right thing to do. So, yeah.
So, really small employer, less than 5 employees. Is this doable?
So the question is, small employer, 5 employees, is this doable? So the short answer is that to be self-funded as an employer and to get adequate stop-loss insurance, usually not that small. I am actually aware of a method now that may be able to solve that problem. There's health shares out there. I will tell you the concepts in the book and the concepts we've talked about today of shopping for value would apply even to an individual or family. So the concepts apply. The biggest thing is to get effective risk management or stop-loss insurance, and that would be the one gap. So the current answer, kind of no, but I've actually got an idea that may develop, so we'll see.
Can you very quickly, this is me.
Mm-hmm.
I am one of Matt's generals in Wisconsin, right, Matt?
Mm-hmm.
Better be.
Yeah.
Can you quickly explain to the audience what stop loss means?
Stop loss is, it's an insurance, but instead of paying just the premium and then having the insurance company take all the risk, the employer would take on, say, 90% of the risk, and then if it gets extreme, either on an individual or in the total aggregate, the stop loss would kick in. So that's, if you're really big, if you're a giant corporation, then you don't even need that, but most self-funded employers, 50 employees up to thousands, would have that stop loss built in. It's kind of a safety net.
So we're all advocates in here, and we advocate shoulder to shoulder with our patients who are someone's employees. And by the way, 2 major payers in this country, number 1, government, number 2, self-funded plans. Our drugs are not cheap. How is that handled on the self-funded employer end when it comes to stop loss or coverage or anything else?
How is the drug related to the stop loss, the drug purchase?
Right, because we are dealing with access here, and you're the payer.
Mm-hmm.
It's not the BUCA. It's actually the self-funded employer. So how can we partner with the self-funded employers to get access for our patients' treatments?
I think it comes down to a truly transparent PBM. So PBMs play a lot of games, right, in general, not to stereotype or generalize, but many of them do. So you need a PBM that's not playing any games. And then from there, you need options. You need the provider side to give you a fair price. Especially if there's 340B, there should be a very fair price where they can get the drug for a penny. But we need options to shop. Those aren't always there right now. But like in this case, we Milwaukee Rheumatology, we can shop there. We can get the drug at a cost, and then pay for the infusion as a normal, more than fair infusion cost. We find in many cases on the infusion side, on the J-code side, that say in TiVo that it should cost say $6,500 to sit in the chair, but then it's billed at $25,000, and they mark up the price of the drug. Is one of the games that is played. So we have to stop the games. Just charge a fair price.
So you figured it out. Congratulations. I mean, really, excellent.
Thank you.
But are you doing anything outside of Wisconsin?
We are actually spreading across the border. We're
Florida.
in Minnesota.
Come to Florida.
I know a lot of people in Florida, Minnesota, Iowa, Illinois, and and just like from our health plan, I think we're maybe pretty unique, but we can leapfrog if there's enough numbers. So yeah, and the book can give you an education of how to do it as well. We just kind of believe in the abundance mindset, share everything, and try to help. So I think you'll like the book if you have interest.
Yeah, I was just going to say, I'm in Michigan.
Mm-hmm.
The original Mitten State, the real Mitten. Just so you know. We're gonna fight.
So in Michigan, we have a lot of self-funded plans, and the issue that we're having, which obviously I don't know if you can really talk on that, is we see an increase in alternative funding plans. We have all of these people that are blocking access, and we're basically having to direct the patients to talk to their employers and asking them to make a change with their health plan. We need you in Michigan.
We may. I've actually met the two largest DPC companies, so Plum Health and Salta Direct. I'm speaking over in Troy in February, so I'll be over there. Yeah, and a lot of it, and I was in this, I mentioned the first 2/3 of my career as an HR professional. I was kind of clueless in this game, and that's where I think most employers are today. They have no idea of the stuff we talked about today. It's not they don't care, but they kind of just look to the seller side and say, what should I do? And they say this, and they smile, and they say, okay, let's go. And they go back to their other job, their normal job. And we just have to start managing, our employers have to start managing the health plan like you do every other part of the business. And we manage office supplies down to the penny, but we'll spend millions on healthcare and waste the money and not blink. And so employers are accountable, by the way, according to the CAA of 21. Employers are the legal fiduciary responsible for this. And we have 3 cases across the country. One of the plaintiffs is here today. We have 3 cases across the country where the employee is suing the employer because they ignored their fiduciary responsibility. It would be the equivalent of your employer buying groceries for you, and you find out they're spending $100 for a gallon of milk and $120 for a dozen eggs, and you're paying 20% of that. And you say, wait a minute, that's stupid shopping. And so employers have the legal responsibility to do that with their health plans now, and they're getting sued if they don't. Yeah. Yeah.
Thank you for this. This is fantastic. I live in New England. I'm an independent patient advocate. I am wondering if you've considered directly approaching pharma to buy drugs from them directly, cutting out some POs altogether.
I think what Mark Cuban is doing is helping with a lot of that. There's a lot of powerful influence there and lobbying, but you're exactly right. I think the manufacturers of the drugs, there's a lot we don't know, right? But the manufacturers of the drugs are on a stranglehold from the PBMs. They say you have to do 1, 2, 3, 4, 5, or we won't sell your drug, rebates and all these money games. And I think if we take out the middlemen in many cases and we just have buyer and seller, we can avoid a lot of those games, right? Where the seller needs to win and the buyer needs to win, but we don't need 3 entities in the middle playing games and really just adding cost and no value. Yeah. All right. Thank you for your time today.